Welcome to Dr. Balga's podcast for the Curious Doc. Today is February 5th, 2026. This video is on a JAMA article published about 10 days ago on Jan 26th, 2026, titled Donation After Circulatory Death or Heart Transplant Without Pre-Implant Reanimation Using Rapid Ultra-Oxygenated Recovery. All the authors are from Vanderbilt. Donation after circulatory death hearts face warm ischemic time limitations. The Vanderbilt group created REUP or rapid recovery with extended ultra-oxygenated preservation, and it avoids reanimation of the donor heart. Typically, there are two methods followed during DCD heart transplantation. The first is called direct procurement and perfusion, or DPP, where the heart is taken out of the donor's body and restarted using a machine. In the second method, called TANRP, or thoracoabdominal normothermic regional perfusion, the heart is restarted inside the donor's body. Both methods can work well, but each has problems. DPP is very expensive, needs a lot of staff and planning, and many hearts prepared this way end up being discarded. TANRP has raised ethical concerns because it may allow blood to flow again to the brain or spinal cord, where some worry could violate rules when death is declared. Because of these concerns, TANRP is not allowed in many countries and is restricted in many hospitals in the US. In REUP, instead of restarting the heart, the REUP technique protects it by gently flushing it for about 10 to 12 minutes with oxygen-rich blood mixed with special heart-protecting solution. This allows the heart to be safely recovered without restarting it inside the body or using a machine outside the body. In early patients, particularly younger donors with shorter periods without blood flow, this method has led to excellent results with no severe early heart failure after transplant. The Vanderbilt team have since used this REUP successfully in older donors, and even in cases where the heart went without blood flow for much longer, showing that this approach may work for many more patients. Keeping this in mind, they conducted a single-center retrospective case series at a high-volume U.S. transplant center, that is Vanderbilt. 24 adults, DCD heart transplant recipients was the sample size. Study period was from November 2024 to July 2025, mean follow-up 167 days. They used descriptive statistics. No comparative hypothesis testing. What did they find? Mean donor age was 32 years. 38% of the donors were older than 40 years. Ischemic profile, mean time from declaration of death to flush was 9 minutes. 60% of the hearts had total ischemic time greater than 4 hours. The longest ischemic time was 8 hours. Early graft function and survival, 30-day survival was 96%. Severe primary graft dysfunction was 4%, there's one patient. Secondary graft dysfunction was 4%, one patient. Rejection outcomes, acute cellular rejection grade 2R or more, 4%, one patient on first biopsy. No antibody-mediated rejection observed. Renal outcomes, 42% required post-transplant kidney replacement therapy, nearly half of the cohort. Limitations of the study, small sample size, single-center design, short follow-up, no direct comparator group. Key takeaway, REUP appears to be safe, feasible, and effective across older donors and prolonged ischemic times. Clinical pearls. Avoiding donor heart reanimation may reduce ethical concerns and logistical complexity. Ultra-oxygenated perfusate plus valproic acid likely contributes to myocardial protection. Low discard rate, 0%, suggests REUP may expand the usable donor pool. Compatible with multi-organ recovery, including abdominal normothermic regional perfusion. The technique may be particularly valuable for geographically distant donors. Read more in the this week's issue of JAMA. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.